Good evening, everyone. I'm delighted to welcome and thank all of you for joining Capital Health Network's webinar entitled Improving Medication Management Through Electronic Prescriptions and Active Script List. I am Ross Trinidad, the Digital Health Manager in CHN, and I'll be facilitating tonight's webinar. Before we start, I wish to acknowledge the traditional custodians of the land we are meeting on, the Ngunnawal people. I wish to acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. I would also like to acknowledge and welcome other Aboriginal and Torres Strait Islander people who are attending tonight's event. So some housekeeping. All participants have been muted. Please address any questions you may have in our chat panel, and we will endeavor to answer them in our question and answer session, which will follow the presentations. This presentation will be recorded, and the link as well as all the resources and presentation slides will be sent to you following the event. Just a reminder as well for all GPs to please encode your RACGP number in the post-event evaluation form so that you can get your CPD points. For other health professionals, you can also self-record this event. So this event is brought to you by CHN and the Pharmacy Guild of Australia. Maybe you're wondering, why did we host this event? So a lot of prescribers and dispensers have embedded electronic prescriptions in their workflow, but we learned that not a lot know about the active script list. So our objective for today is to inform all of you what active script list is, how it works, how you can incorporate it in your daily workflow, and the benefits of ASL, not just to healthcare providers, but definitely for patients. ASL is beneficial for patients, especially those who are taking a lot of medications. For GPs, practice managers, and nurses attending today, it'll be good for you to see how ASL works as well on the pharmacy side so that you can also encourage patients to register. All right, so for tonight, we have 4 presenters. We've got Dr. Kathy Rainbird from the Australian Digital Health Agency, Regina Cowie from Fred IT, we have Mark Leighton from Lanyon Pharmacy, and Amanda Galbraith from ACT Health. First up, we have Dr. Kathy Rainbird. So Dr. Kathy holds a PhD in behavioral science in relation to medicine and is a manager of education and adoption at the Australian Digital Health Agency. Kathy is based in Western Australia and has been working with Aboriginal medical services and other healthcare providers, both across WA and nationally, training them in the benefits, features, and clinical use of My Health Record and other digital health tools. So please, let's all welcome Kathy.
Thank you so much, Russ. I'm just going to share my screen and put up my slides there. Can you see my slides now?
Yes, we can. Thank you.
Lovely. Thank you so much. So thanks for the introduction. I won't reintroduce myself, but I am from the Australian Digital Health Agency, which is the national agency that is delivering a range of different digital health products and services across the country, and electronic prescribing and the active script list is one of those. So I'll push on. I would also like to acknowledge the traditional owners of country throughout Australia and their continuing connection to land, sea and community. I'm speaking to you this evening from the Menang country, part of the Noongar Nation, and I pay my respects to them and their elders, as well as any Aboriginal Torres Strait Islander joining us for this evening. So I'm sure most of you are aware of where scripts how they've changed over time, but I also give a bit of background about what is happening in the background with the new electronic transfer of prescriptions and how that supports the electronic script process. And then we'll dive into more detail on the options for the management of those electronic prescriptions, and that includes the active script list. Talk about the benefits of using that script list, share a little video with you, talk you through the registration process, and then we'll either have questions then or wait until the end of the whole presentation to go into questions. So I'm sure all of you are familiar with how paper prescriptions have changed over time. So the old script pad was pretty unreliable in terms of being able to interpret writing, use of acronyms, all sorts of transfer of information issues, and safety and quality concerns in terms of making sure people were getting the right medicines. So the next step was to have computer generated scripts, but those are still paper prescriptions. They still needed to have the bit of paper to take to the pharmacy to get that script filled. At least it meant that the information was clear and legible, easy to read. No offense to any of the GPs in the room, but it just meant that those errors were less likely to occur. A good first step. The next step was when we had the introduction of the electronic transfer of those prescriptions. So you can see on that last screen, it's got a barcode on the script. And that means that the information stored written into the software at the GP end is transmitted to what we call the Prescription Delivery Exchange Service. So this is just a bit of an overview of that flow. So it's from the prescribing system. We've got the barcode included on the paper script. We're still talking about a paper script, even though it's generated on a computer and has got that barcode. And the information is then stored in the prescription delivery service. When that script is presented to the pharmacy and scanned, the barcode is scanned, then the information from that script can be downloaded. And of course, that improves safety and quality and in terms of that dispensing of that medication. So the information is delivered, but the paper script still needs to be presented because that's the legal prescription. The next step is that we now have our electronic prescriptions, and that's where the legal prescription is actually stored in that prescription delivery service, and the token or the code that's put onto the patient, sent to the patient's phone, is what's used to unlock that legal prescription and download it from the prescription delivery service. So the token itself is not the script, but it's what the patient receives and takes to the pharmacy, but it's actually the script itself is the electronic form that's stored in that prescription delivery service. So in a nutshell, electronic prescriptions are just an alternative to paper prescriptions, where previously only the paper prescriptions signed by the prescriber were the legal form. So we had to actually introduce new legislation to ensure that electronic prescriptions could be allowed. And that's of course now happened across the country, thanks in part to being fast-tracked due to COVID. Electronic prescriptions are not mandatory. You can still use paper scripts, that's fine. It's up to you and your patients as to what is your preference. Of course, if someone is isolating or is needing to keep away from other people, then having the option to provide an electronic script, especially if you're doing a telehealth consult, can be very, very useful. So in case any of you haven't experienced what those tokens look like, this is what it looks like from the patient end. If you're in the GP's software, if you click on yes, send it as an electronic script, you need to confirm the mobile number with the patient, make sure it's going to the right mobile phone, and they'll get a message on their phone, which then indicates that there's your prescription. They tapped on the message and they'll see this little indicator saying, tap here to view your script, which, as I just said, it's not actually the script, it's the token that unlocks the script. Then they can see either this sort of view, there's a couple of different forms of it here, but basically, as I said, it's this QR code that then unlocks the actual script from the prescription delivery service. These are just a couple of other screenshots to show you what it looks like to the patient if there's been a expired or dispensed or cancelled script. So just so you can see what that looks like. So that code you can see has disappeared. So there isn't a chance for them to use that token multiple times. Once it's been dispensed, it's not available through the PDS anymore. And for those patients who perhaps don't have a mobile device, there is the option to send a patient their token by email, or even to give them a printed bit of paper, which seems a bit reversed or a bit of a strange way to do it for electronic script, but that is an option as well. If your business hasn't yet enabled electronic prescription, there are a few things that you need to do to get it set up. And if you're already connected to the Health Identifier service and have an HPIO number, then you're well on the way. If you haven't got that yet, then there's information through that hyperlink which guides you how to get that healthcare provider identifier for your business or organisation. It's the same number that underpins the My Health Record system. So if you're already set up and using the My Health Record system, you probably already have an HPIO number. You'd have to, so that you wouldn't have to worry about doing that. You also need to have installed a NASH certificate, and you need to have connected to a prescription delivery service such as ERX or MediSecure. Your software might need to be upgraded and those identifiers included in the system. The agency has a lot of information and useful resources to support in this space. And if you need help getting to the point of getting your HPIO number, that we have a connections team who can help you with that. So in terms of how patients can then manage their scripts, they can just collect the multiple tokens if they have multiple medications on their phone and they just have that token or emailed to them. They can have the SMS or email sent to a carer or agent on their behalf, such as a parent for a younger person can receive the script on their behalf. And there are a number of mobile apps that are able to store tokens as well. So a lot of pharmacies have some of those set up, and they can choose if a patient goes to a regular pharmacy, they can choose to use that particular app to store their tokens. And then there is the active script list, which requires the patient to actually register and say, yes, I want to have an active script list. And that's done at the pharmacy end. So the active script list, as Russ mentioned at the beginning, is particularly useful for patients who have lots of medications. It's a way of managing those tokens so that they don't have to search through their phone to find the relevant medication and the relevant token. All of the active prescriptions and repeats are able to be dispensed. So the patient just needs to go into the pharmacy and get set up and registered. And some pharmacists, as we'll hear later on today, are in the process of doing that for patients and finding it really useful. Then pharmacies can access that electronic prescription for the patient from the active script list, as long as they've got the proof of identity of the patient. So we've been talking a bit about patients taking regular multiple medicines, and it removes the need for them to manage those multiple tokens. It's also really beneficial for patients who have scripts on file. The pharmacy can just have those scripts on the electronic file instead of a paper file. And if a patient has lost a repeat token, they don't have to worry, because if they're registered for ASL, they don't actually need the token itself. It will appear in that active script list and the pharmacist can still dispense the medication. So in terms of the process of actually getting set up, the patient needs to attend their pharmacy of choice and request to be registered, or the pharmacy or their doctor might suggest that they get set up and registered for ASL. That's done at the pharmacy. Once they then go and attend the doctor and get their prescription, that's sent as an electronic script, and then it's automatically added to the ASL, unless they specifically say, actually, I'm having this prescription for this particular medication, I don't want that on my active script list, and then the patient can request that that's not sent to the ASL. So provided they haven't done that, the script will be generated and put into that active script list. They can still get a token if they want, but they don't even need to. The patient then presents at the preferred pharmacy, confirms that their identity, and can receive the medication. And if there are any repeats, then that will be added to the ASL, depending on the patient's preference. So I've now got a little short video. I'll just jump out of my slides and jump into the video display and hope that you can hear my sound. Just let me know if you can't hear this whilst I'm playing it, Russ.
When you visit your doctor for a prescription, you can now choose an electronic prescription for your medicines. An active script list is a digital list of all your electronic prescriptions and is helpful for people who are taking multiple medicines. When you have an active script list, you no longer need to keep track of each electronic prescription token from your doctor or pharmacy. You will also not need to worry about losing your electronic prescription tokens. It can assist your doctor and pharmacist to help you to manage your medicines more easily. You can register for an active script list by speaking with your pharmacist. You will need a mobile phone for registration, and you may be asked to provide documents to prove your identity. You can also nominate a carer or family member to help you look after your active script list and collect your medicines. Once you are registered, any electronic prescriptions that you receive will be automatically added to your active script list. However, you can choose for some medicines to not be added by speaking with your doctor. When you visit a pharmacy, let them know that you have an active script list. Each new pharmacy will ask for permission to access your list. You can control which pharmacy has access by responding to an SMS or email. The pharmacy will then supply your medicine without you needing to show a copy of your electronic prescription token. To register, speak to your pharmacist. For more information, visit digitalhealth.gov.au/electronic prescriptions.
So that little video is, of course, from the consumer or patient's perspective, but it gives you a bit of an idea. And those of you who were switched on might have noticed that when the SMS from the pharmacy comes through, the patient has to confirm that, yes, they want to be registered for the active script list. And as part of that, they can say, yes, this pharmacy can have access all the time or just for a specific day. So they can say just for a short time. So that's if people are traveling around the countryside, they can actually go to another pharmacy and say, I've got an active script list, which is in my hometown, but I'd like you to have a look at it here because I need this medicine dispensed. So one thing to point out is this is what it looks like from the pharmacy end. You can see the list of the different scripts here. Those with the token hyperlink are the ones that can be dispensed using the active script list without needing to see the token. But the ones that are listed as paper can't be actually clicked on with the hyperlink, so they can't be dispensed. They still have to present the script in order for it to be able to actually be prescribed. So that's just a safeguard in place to make sure that it is only those ones that are generated electronically that can be prescribed through this active script list. But at least you can see all of those other medications as well. In terms of if a patient doesn't want to have an active script list, if they have a reason to say that they don't want a particular script added, if they will need to have their details added to the prescriber to withhold it from their script. So they can say, if in this case, I don't want this medicine uploaded, so it can exclude it from the active script list. So this is a screenshot from Medical Director. And this is a screenshot from Fred Dispense, I think, or Aquarius, sorry. So finally, I'd just like to point out how there's been a huge increase in, of course, the use of electronic prescriptions, again, fast-tracked because of COVID-19. Since May 2021, over 77 million electronic scripts have been created, which is phenomenal considering before that no such option was available. And you can see the trend for the active script list is also on the up, which is fantastic. And I think we'll hear from one of the pharmacists on the panel tonight about how useful it is at the pharmacy end. We do at the agency have a whole lot of resources to support you. We also have a free e-learning modules that you can complete if you wish to learn more. We do have a web page with lots of different fact sheets and so on. And there are also links on this slide to some of the Department of Health's resources, which include some of the policies and frameworks behind the system if you are that keen and you want to read about those. And that's it from me. Thank you, Russ.
Thanks, Kathy. Thanks for giving that background regarding eScripts and active script list. As I'm aware, we have a lot of presentations, so I can see there are questions coming through. If it hasn't been answered yet, we'll discuss it at the end of the sessions. So our next speaker is Regina Cowie. Regina has a Bachelor of Sports Science and is a qualified accredited pharmacist. She has over 20 years experience in community, industry, and corporate pharmacy. She developed the first intern training program for the Northern Territory and Pharmaceutical Society of Australia. She worked for Australian pharmaceutical industries for 8 years, recently the National Healthcare Services Manager. She led her team to successfully implement electronic prescribing into Priceline Pharmacy, Sol Pattison, and Pharmacist Advice. Regina has a passion for service delivery with care through innovation and technology. She is the Partnerships Manager in eHealth for Fred IT and holds a pharmacist position on the Victorian Pharmacy Authority. Welcome, Regina. Thank you.
Thank you. Thanks, Russ, for that introduction. I'm here today to talk to you about the active script list, and we refer to it as the My Active Script List because it really is your script list. Thanks for sharing my presentation. I've got some helpful tips on the My Active Script List. Some benefits has already been articulated and described in the previous presentation, and a quick video to show you exactly what the registration process looks like. So hopefully you'll enjoy this and you'll get a bit out of it. Next slide, please. So we've seen this real evolution of electronic prescribing, starting from the e-tokens through to the MySL, and we're now looking at MySL intermediaries. So we're talking about third parties here, enabling customers and patients to access their MySL. So at the moment, no patient can actually view their MySL except for a WhatsApp functionality, which I'll show you later on in my presentation. And then we've got the final step, which is e-medication charts, which obviously will be a great success story in the aged care and community setting. Next slide. We've seen this amazing rate of change in technology. Really thank you to coronavirus, in my opinion. Possibly 10 years of legislation was changed in about 10 days and really has escalated this telehealth e-prescribing phenomena. Next slide. I wanted to just show you some data. So this is some MBS data, which is quite phenomenal. And as you can see down there in the bottom panel, the total number of telehealth consultations since COVID is incredibly massive. We're looking at 111 million consultations. So a really great success story. And the MBS consultations there are 444 million. In Q2 of 2022, 11.6 million telehealth consultations. So a huge increase in the way we deliver healthcare, really as a coincidence or not with COVID, really moving this into a great space and access. As you heard from Russ's intro, I worked a bit in the Northern Territory, and I would love to have all this technology to enable people to access healthcare up there 20 years ago when I was working up there. Next slide, please. Just a little bit more data on the success of electronic prescriptions. So these are our current statistics from October 2022. There have been 83, nearly 84 million electronic scripts, which have been created by you, the prescribers on this call. So thank you. 38 mil created by doctors and 45 mil created by pharmacists. So that's the repeat. But what you can see here, which I really did want to highlight, is although there have been 38 million prescriptions created, only 30 million have actually been dispensed. So electronic prescribing really does give us data and insights into adherence and compliance to medicines and the opportunities that they actually bring to the table to identify why this 8 million gap since the inception of electronic prescribing. So there's a lot of work going into the background and the data within that piece, but it's incredibly helpful to see what's happening. But a great result overall, really good success story in electronic prescribing. Next slide, please. This has been the pharmacy and doctor uptake, and as you can see, the pharmacists really have reached saturation. There's only about 5,600 odd pharmacies in Australia. So by January 21, we'd reached really that saturation point. There's no more pharmacies. They were 100% pretty much. I probably wouldn't say 100%, maybe 99% of pharmacies are able to dispense an electronic script. There's always an outlier anomaly. But it's a great success story in pharmacy. But as you can see on the blue line, this is the prescribing numbers, and they're slowly increasing. So they continue to increase. I know this graph stops at September 2021, but it is still this gradual incline of doctors embracing technology. What is interesting about this, although I did highlight that their pharmacies have reached saturation and all pharmacies are electronic enabled, only 80% of pharmacies have embraced the MySL. So that's really quite interesting, which I'll touch on a bit later as to why that might be the case. Next slide, please. What we love to see is integrations, making not only the prescribing software integrated, but also the dispensing software integrated and easy for pharmacies. And this is one of our Fred dispense platforms. We've got many, but this is just one I wanted to highlight. And you can see that the pharmacist has one screen with all the integrations. So I can click on this My HR record, for example, and access the patient's My HR, but I can also click on this button and access their MySL. It turns green once they are registered. So in this case, this patient isn't registered, but the more integrations you can have, the better. So if you're using a particular software, be it prescribe and or dispense, please make sure you talk to your software vendor and ask them to make sure that it's all integrated. You don't want to be jumping around through different screens. It just interrupts your workflow. You want efficiency, obviously. Next slide, please. We've heard a little bit about electronic prescriptions and the benefits of MySL. But I just wanted to touch on a few other little bits and pieces. So there's some really key opportunities here for patients to fill their scripts in different ways. When they have an electronic script, they can send it through an app, and that can include a pharmacy dedicated app or a WhatsApp. They can SMS it through to the pharmacy. They could do a click and collect delivery, or they can actually present in person and get it scanned and dispensed in the pharmacy. It really does improve adherence benefits for the patient as well, and lots of efficiency gains for the pharmacy. There's no more paper, no faxes, to and froing trying to find this piece of paper. It is all stored safely in the cloud. It allows flexibility for prescribers, so those especially working remotely or via telehealth, to provide their patients with an electronic token if they do require a prescription after that service. Lots of data utilisation, which I mentioned, my health record, but also the National Data Exchange, which is the real-time prescription monitoring service across different Safe Script. I think it's called Safe Canberra or Safe SQ in Canberra. And ACT, and there's obviously great strength in the IT security around electronic prescribing. Next slide, please. So the active script list, just on the My Script list, is this virtual script drawer in the cloud, all safely stored. There's no need to search for your tokens, as was mentioned previously. Next slide, please. But what we're seeing is not a great result in the numbers. So we know the population of Australia is hovering about 27, 28 million, yet we've only had 500,000 patients, Australian citizens, register for a MySL, which is not a great result. And I did touch on the pharmacies using it, sitting about 80%, and there's only about 6.4 million scripts in the MySL. So numbers that are very, very disappointing, because we all know the benefits, but numbers that we hope with webinars like this and education, we continue to see improved and increasing. Obviously, we aim for almost everyone to have a MySL. I still do some locum shifts in a pharmacy, and one of the registered MySL patients came in and had her bags stolen, which didn't matter. Even though her tablets were in there, I was able to access her MySL and know exactly what medicines she was on and give her her medicine. So without having to contact the doctor or provide owing scripts, even though we shouldn't really be doing that, it really is that duty of care continuum of medicine. So there are some great benefits in the MySL space as well. I could talk many examples, but I've only been given an allocated short amount of time. Next slide, please. So these are the patients' apps that were being referred to previously, and I'm sure there's many others, but MedAdvisor and My Pharmacy Link, which is now incorporated as one, are really the two key patient apps out there at the moment. Next slide, please. However, at this point in time, the only way for a patient to see their MySL is using WhatsApp. So luckily, about 6 million Australians use WhatsApp every day. So it is, quite well known. And I've put some links in there for you to just access on your own time if you want to know a little bit more about how your patients and all your customers can access their MySL and order their MySL from their local pharmacy using the WhatsApp function, which is free, safe and secure. Obviously, we don't have time for those today, but please, they're only a couple of minutes. I encourage you to watch them in your own time. Next slide, please. You saw this in the previous presentation, but this is what it looks like. So you can only, when you have a MySL, you can only utilize the token. So it has to be an electronic script. If it's a paper script, I can't do anything about it. So I can see that this patient has ditropan 5 milligrams, but I know it's paper. So I still need that paper script to process it. Yeah, the mini press, the one above it, 5 milligrams, I know it's a token and I can then press that button and dispense away. So there's still a little bit of an issue with the fact that there are still paper scripts floating around, and there always will be. But the more that we can have electronic scripts prescribed, the more complete this MySL looks for the patient. Next slide, please. So I wanted to give you a short video of the MySL. Unfortunately, I couldn't get a test site in short time to show you exactly what this looks like, but this is an end-to-end demonstration of how a pharmacist registers a patient for MySL. It takes about 2 minutes.
Register them for MySL. Today, one of my regular patients, Sally, has arrived at my pharmacy with her token script. She's a bit unsure about the SMS tokens and how she can manage them all with her repeats. Sally normally leaves her scripts with me and I manage her scripts for her. I talk to her about whether she would like to register for MySL. I tell Sally the MySL is an optional free service and it requires me to get her consent. I suggest one key advantage is she will never lose her scripts again as they are all stored electronically, and she doesn't need to get the SMS or emails each time she sees the doctor. If she gives me permission, then I can always look after her script needs and see what scripts she has available when she comes in or calls me for delivery. Sally thinks it would be a great idea, so agrees to the registration. At the scripts encounter, I'll use MedViflow to search for Sally who already exists in my dispense system. I'll select Sally, and back on Scripts In, we can see the MySL Register button. We'll press that and view the registration form, which is already pre-populated with all of her details from dispense which are required for registration. I'll confirm with Sally that her preferred contact method is her mobile phone, which is where she'll receive the consent request for my pharmacy. I'll press Submit, and right away Sally will receive a text message with the following message. Sally replies to the text message with number 1, which will give my pharmacy unlimited access to her MySL. Any of Sally's prescriptions that exist in the prescription exchange, which include both ERX and MediSecure, can now be viewed in her MySL by me at any time. It's worth noting here that the MySL is not a full patient dispensing history like you see in the MyChart. It's simply a list of your patients' available original and repeat prescriptions. Today, Sally's wanting 2 of her prescriptions dispensed, so I'll select those scripts and press Next. Sally wants to do some shopping and grab a coffee, so she'll come back later. I'll process her scripts and queue them for the pharmacist to dispense from MedViflow as normal. And that's it. It's important to note the patient registration for MySL is a once-off step. and obtaining pharmacy viewing consent is simple via the SMS or email to the patient after that. MyCell makes it so easy to look after your regular patients without the need for SMS tokens, emails, or paper files of prescriptions.
Great. So you saw how quick and easy that registration process is. And if you are traveling, which I saw was one of the questions, you just need to re-register, and you can grant permission for 24 hours at that particular pharmacy to access your MyCell if it's not your regular pharmacy. So it enables you to access your prescriptions anywhere in Australia, which is fabulous. I've just got a final slide. Excellent. So really, this is my final message, and it really is about, regardless of where you sit in the community, it's about educating your community, your customers, your patients, prescribers, anyone you come into contact with, on what the MyCell is and the benefits, because it really is an incredible asset to be able to have this, and to only see 500,000 Australians registered is quite disappointing, but let's work together to increase that number. Really sign up as many customers, if you're a pharmacist on this call, to the MyCell as you can, because it really does improve patient care. And I always try and have some focus areas. And when we're rolling this out, in my previous role, we focused on these areas. You can pick whatever you like, but here's some suggestions. Focus on those that are presenting with an eScript token, because they're obviously very familiar with electronic scripts, or regular customers, or those with chronic conditions on multiple medicines, or your dose administration aid patients as suggestions. But you can sign up whoever you like. But focus and targets usually work quite well. And my final message is the MyCell improves patient health outcomes, efficiency, and patient safety. So it's a great tool. I encourage you all after this to go out there and sign up and talk about this great asset. And I've left you with some resources on slide 16. I'm happy for us to share this presentation with some of those links as well. Thanks everyone for listening.
Thank you very much, Reg. That was really a great demo of how the active script list works, and thanks for giving some tips. I can see some questions coming in. Again, we'll just go through all the presentations before we answer all those questions. So our next speaker is Mark Leighton. Mark is the managing partner for Lanyon Pharmacy in Conder and has been a community pharmacist for over 15 years. He worked in the community and hospital pharmacy both in Australia and New Zealand, and he is currently a member of the Pharmacy Guild ACT branch committee. Thanks, Mark.
Thank you. Thanks for giving me the opportunity to talk. Just bear with me for a moment. We'll get started. So as I said, just a few declarations, just so you know where I work and where I fit in. So I'm a pharmacist at Lanyon Pharmacy in Canberra, Arundel, and also Queanbeyan Pharmacy, where I work as a pharmacist. Local partner in Lanyon Pharmacy in Conder in Canberra, Coolman Court Pharmacy and Queanbeyan Pharmacy, and also an ACT branch committee member for the ACT for the Pharmacy Guild of Australia. So I gave a talk probably last year, I think it was, and this is the exact copy of the slide I gave, but basically it's a patient benefits for the electronic tokens. So with electronic scripts, unless the prescribers cancel the script, you can't actually lose an electronic script. There's lots of ways to find it. It improves the patient and community safety, so less forgery scripts going around. We all hear about the ones that are forged and people try and access certain types of medications. Patients have greater control of the prescriptions. So as I said before, regardless if they lose a bit of paper, there's not much we can do, but with an e-script, then there's a way to find it somewhere if it hasn't been cancelled. Prescribers can easily cancel a token if they like. So just say they've gone up from one particular strength of medication to another. They don't have to call the pharmacy and go tear up that script. They can actually cancel it from their end quite easily, and they can have full access of what scripts are actually out in the community. Current up, that's an old one, but I think there are upgrades coming through. So you don't actually need a smartphone anymore or the QR code with the active script list. It just removes the smartphone QR code, especially for those people who really struggle using the phone, using technology, resistant to change. And I'll go into that, a few more of the roadblocks a bit later. there's also the ability to link your electronic prescriptions to the pharmacy app. So I think I talked about the WhatsApp earlier, so that's one option. The MedAdvisor and My Pharmacy Link are two other, the more common options in community pharmacy. Currently with the active script list, patients can't see what scripts they've got, but they can actually view these scripts through the pharmacy app. So that's just another way they can get some visibility of what they've actually got. From a pharmacy point of view, so the opportunities and the benefits are, it increases the efficiency of the dispensing process. So things go through quicker because you're not manually entering as much data. It's a lot more accurate, less dispense errors, which again, that'll improve the patient outcomes. Reduce risk of duplicate scripts being dispensed. As I said, if a doctor wants to delete a particular medication or token, they can do that quite easily and replace it with an alternative. Less admin tasks. So back during the COVID pandemic, there was the digital image-based prescribing, which now isn't allowed anymore, but we could do it by that, but you had to chase up the copies. Faxes still come through, but from a pharmacy point of view, there's still a lot of administration that comes with a fax. I've got their reduced owing prescriptions, and that comes with the faxes. So for those who don't know what an owing prescription is, it's basically when a prescriber phones the pharmacy and goes, can you dispense this, or they send through a fax. Now it's important to note those owing scripts that we do, we need to wait till the original comes in, and we actually don't get paid by the PBS until those scripts come in. So if we dispense a $1,000 COVID drug and we don't get the paper script for another 2 or 3 weeks after, that's money that isn't coming back in to pay for the stock that we're sending out. As I said, lost scripts can easily be found, and also, as you probably know, when patients lose scripts, it's usually the pharmacy's to blame for it because they've lost it, or they've put it through the wash, or they've torn it up accidentally, or it's been stolen. As I said before, you can't lose an e-script, so it's easy to find, and with the MyCell, it's easy to find scripts that they think they might have missed. Just moving forward. So currently with the electronic tokens, and this is not part of the, sorry, this is not the talking about the MyCell, which we'll go into that in a minute. There's a number of ways people can get their electronic tokens. So they can either get it through an SMS, an email, either directly from the prescriber or the patient. Their doctors can print the QR code, they can print the email. There's the pharmacy apps. And through some dispensing software, we currently use the FredNext software. There's the ability to actually regenerate a token quite easily through a patient's history. There are limitations to that, but that's just another way you can actually access the electronic scripts. So there are quite a number of different ways and options for patients and their preference. And basically, as the token is dispensed, then a new token is created. So some common roadblocks that we find with e-scripts are the phone's not compatible, or there's no data or Wi-Fi in the pharmacy. If you're in a shopping centre, you may not be able to get data to your phone, so then you actually can't download the QR code. They may not have credit on their phone, so again, they can't open the message. Limited knowledge of technology. They might have deleted the SMS, they might have lost the email, but again, we can generate those quite easy. And some are just resistant to change. They used to go into the prescriber with an issue, walking out with a physical paper script. Now they're not getting that, so it's just trying to retrain and re-educate those sort of patients that this is still a valid script and it is safe and it can still be used. And sometimes the barcode scanners aren't working in the pharmacy. You need to have a special type of scanner. Has to be a special QR code scanner. Older style scanners may not work. So that's just a few roadblocks that we get. But as you see, there's multiple ways to get a token that may be presented to a pharmacy. And there's quite often a lot of confusion with the patient trying to explain what they're trying to do. So you get comments like, it's a digital script, it's an electronic script, it's that stupid thing on my phone. We get lots of weird and wonderful interpretations of it. So the advantage of MyCell is it cuts all that out, so it just reduces confusion. Again, it does come down to the patient's knowledge and how they actually communicate it to the pharmacy staff what they're trying to say. But this is just a quick example, and you've seen some pictures of the active script list. This is for one of my patients, and before people ask, yes, I did get permission to use this off the patient. So now the doctor will prescribe an electronic token. It goes directly to the active script list if they allow it, if the patient allows it. Sorry. The tokens dispense and then the repeats show up here. So you can sort of see here, this patient here, they've got quite a number of medications. And you can actually go through and tick, and if they want like 5 or 6 different medications, you don't have to bring up 5 different QR codes, which is more important. Because each individual barcode that you have to bring up takes time. Here you can actually just tick the ones that you want and push them through. Also gives the, I believe, the prescribers visibility of what's being dispensed, so they can see that the pantoprazole from the 9th of 9th hasn't been touched yet, the QR code down here, if you can see my mouse. So the prescribers should be able to see what's been dispensed and what's not as well. And also from a pharmacy point of view, I think you can see there's a couple multiple scripts for the same medication. So if they run out of this prescription, say that was written on the 4th of the 8th, with the active script list, you can also see there's a brand new one ready to go for the 9th of the 9th as well. So it's very limited information on here. As you can see, it doesn't give too much details away, but it's a good, handy way to put through multiple tokens at once. And then that'll feed into the dispense software, and that'll go through the dispense process as well. So happy to take more questions. If you'd like, you can email me as well, or the phone number there is the Lanyon Pharmacy phone number. So I'm usually down there, but they'll know where to find me. But email is quite good as well. If you've got any questions after this, you can feel free to shoot them through. Thank you.
Thanks a lot, Mark. That was really handy, especially knowing the roadblocks. We've been hearing that as well from our interactions with GPs and pharmacists. All right, so last but not the least, we have Amanda Galbraith. Amanda is the acting chief pharmacist and senior director of the pharmaceutical services section of ACT Health. She has worked as a community pharmacist for more than 25 years in the ACT and NSW, where she has contributed to patient care as both a clinical pharmacist and owner of several community pharmacies. Amanda is also a diabetes educator and board director of a few pharmacies and health-related not-for-profit boards. Tonight, Amanda will talk about Canberra Script. Thank you.
Thank you, Russ, and good evening, everyone. You've already given an acknowledgement tonight, but I'd just like to say Yuma, which is the Ngunnawal for hello. This evening, I'm here to talk about Canberra Script. If you'd like to go over, Taylor. Thank you. It's the ACT version of the National Real-Time Prescription Monitoring System, and it replaces our ageing drugs and poisons information system and DORA, which was the online remote access version of that. These were deployed in 2014 and 2019. And Canberra Script, you can go back to the other one, Taylor. I'll let you know when to go over. Thank you. Canberra Script provides information on any patient in the ACT who has been prescribed or dispensed our monitored medicines. It's intended to support clinical decision-making and ensure medicines are used safely and effectively. It enables health practitioners to better identify and manage patients who may be at risk of harm or dependency. Next slide, please. So why do we need Canberra Script, or more generally, real-time prescription monitoring? Sadly, we now know that since 2008, all drug-induced deaths have surpassed the road toll. And over the last decade, those drug-induced deaths are more likely to be due to prescribed medicines than illicit drugs. We've also seen a threefold increase in cases involving opioids, and benzos are the most commonly included class. So it's not really surprising to learn that there have been very many coronial inquests throughout Australia, where coroners have recommended the implementation of real-time prescription monitoring to help save lives and reduce harms. However, I'm pleased to say the calls have been heard, and I think I'm almost in the position where I can say the entire country has real-time prescription monitoring in place. And the benefit of this arrangement is that the system interface across all jurisdictions is practically the same, albeit they have a different name. So ours is Canberra Script, New South Wales is using SafeScript, but the process of how to use it is the same. And eventually we aim to have cross-border data sharing to support health professionals and patients even further. Next slide, please. Subsequent to the Minister's health declarations in August 2021, Canberra Script now monitors a broader range of high-risk medicines. So these now include all benzos, codeine and tramadol, pregabalin, gabapentin and quetiapine, and the Z drugs. This also includes all forms and strengths of these medicines, even if prepared in combination with a non-monitored medicine, so for example, your Panadine Fort. And our aim and hope is that health practitioners can use this broader view of patient medication data to better identify patients who may be at risk of harm or dependency. And especially we're looking at those patients who might be at risk from polydrug use. But I want to be very clear that Canberra Script is not intended to disadvantage patients who have a clinical need for a medication. Rather, what we're working towards is an informed community of prescribers and pharmacists who willingly and confidently engage with Canberra Script to identify concerning patterns. And we want you to feel supported to have impactful conversations with your patients and to feel that you can do something to assist that person in front of you. Next slide, please. So the benefits of Canberra Script over our older DAPAS and DORA include the information about those scheduled S4 medications I mentioned earlier, information about prescribing events when prescribed on your prescribing software, obviously not handwritten scripts, and dispensing events. And real-time notifications to prescribers and pharmacists via your integrated practice software that appear when prescribing or dispensing a monitored medicine. Real-time alerts in the Canberra Script portal are triggered where the patient's treatment signals a risk of harm. So for example, if a patient has seen more than 3 prescribers in the last 60 days. Now, sometimes that might be quite valid. They may have seen a GP and then a specialist and back to the GP at the practice. But the idea is for you to make an assessment of that and whether it's a risk situation or just normal patient care. The self-registration process is secure and streamlined, and you have the ability to apply for CHO approvals directly via Canberra Script. Next slide, please. So to register for Canberra Script, you'll need to have the email address you register with AHPRA because the system does check your registration with AHPRA, your AHPRA number and your date of birth. And prescribers will also need their prescriber number. And the registration process is pretty simple, takes about 10 minutes. You can just go to that Canberra Script website that's listed there, or Google Canberra Script works too. However, if you need additional support, please contact my team for help, and there's some phone numbers on the last slide. Next slide, please, Taylor. So once registered, you can log into Canberra Script, and this screenshot from our test environment for a patient who is not a real human shows how simple it is to search for a patient. So you can see in the top there, you actually only need to enter 3 letters for first and surname. You don't have to type in the whole patient's surname or first name. And then down the bottom, you'll see Carla Espy with her address and date of birth, and you can then click on her to look at the records. So if you can go over again for me, Taylor. So here's Carla, and this slide gives you an idea of what information is available in the system, including if the patient has any alerts associated with their monitored medicines and the prescribing and dispensing events. So on the far right, you can see the blue prescribed events and the green dispensed events. And down on the left-hand side, those alerts. So green for minor alert or okay to go ahead, orange for something you might need to look at, perhaps it's a different GP but in the same practice, and red, as I mentioned, where the patient may be exhibiting signs of medication-seeking behaviours. And you can also see on the top right-hand side there, the View Access History tab. And this provides a list of any Canberra Script registered health practitioner, pharmacist, doctor, prescriber, nurse practitioner, who has viewed the patient's profile. And the system does log both searches for a patient as well as accessing that patient. So both this page and the previous page, we can, other practitioners and patients can see. So I just want to give a reminder that prescribers and pharmacists should only be accessing Canberra Script patient profiles to inform decisions in relation to the prescription or supply of a medicine to a patient under their care. And do take time to review the terms of use when you log in, and the link is on the bottom of the login page if you need it. Over to the next slide, please, Taylor. So there are a variety of resources available to support you with using Canberra Script, including the Canberra Script website, and we have 5 e-learning modules on the website. You can just Google Canberra Script to get there or use these links. And Canberra Script has a suite of help topics that feature everything from how to register, manage your account to the notifications features. But always, if you require technical support or have any general inquiries, please contact my team and they'll be more than happy to help you out. Next slide, please, Taylor. So to close, I'd like to remind you all of our key message, that Canberra Script is intended to support clinical decision-making and facilitate the safe and effective use of monitored medicines by enabling prescribers and pharmacists to better identify and manage patients who may be at risk of harm or dependency. So if you haven't already done so, do please register for Canberra Script today. Thank you, Russ.
Thanks, Amanda. May I now request our speakers to turn on their cameras, and we'll proceed with our Q&A session. And before I read the first question, also a reminder to everyone who's attending that our Health Pathways team, there's also a Canberra Script referral pathway in Health Pathways. Thank you. Okay, so our first question. If a patient requests a token to not be sent to ASL, but subsequently loses the token, would the pharmacy still be able to retrieve this token?
Do you go, Mark?
Oh, sorry. Look, if it's not on ASL and they don't have the token barcode, I'll probably have to say no. Yeah,
I was going to say the same thing, Mark. Yeah. If they've said I don't want it on the active script list, then the pharmacy can't get it unless they present the token.
Thank you. Next one is, if a patient was also a carer, could they use WhatsApp to find out both their own ASL list as well as the person that they cared for?
The answer is yes, and that's pending the registration process. So when you register for the MySL, you indicate if it's for yourself or if you're a carer of, let's say, a minor. So within that registration process, it then enables you to access those MySLs that you've been consented to.
I also wanted to read an earlier question posed by Peter, and I know Mark has already replied, but in case everyone hasn't read it yet. So if someone is traveling around Australia, can they go into any pharmacy who can access their ASL? Mark, would you like to expound? Thank you.
Quickly, yes, they can. They just need to go to each pharmacy. So if they go from, say, Brisbane to Townsville to Darwin, they just need to find a pharmacy there and register at each different pharmacy.
I'll just add to that, it doesn't take long, as you saw from that video, to register. So you can go into multiple pharmacies, although what we actually see in the data is most people register with one, and they're loyal to that pharmacy, unless they're traveling, for example, or they're caught interstate. So the process doesn't take long, as you saw, and it does happen, but it is rare that people do go and seek consent from another pharmacy.
Thanks, Reg. A question from Sue. How does the pharmacist deal with non-English speakers in this process, especially setting up MSL, or is it ASL? Yep.
I guess there's a case with anything. Hopefully you've got staff that can speak that language. We've got the opportunity where I work that we do have sort of multilingual staff. Not every pharmacy is like that. There are services available. I'll flick that over to Reg so she
Yeah, thanks, Mark. There are interpretation services available, so just Google it. And if they're unable to have someone who does speak English to relay the message to them, there are some services out there to help support those from another with another language.
Thanks. Another question that we have from Judith. Can a practice nurse have access to Canberra Script to check on scripts for the busy GP?
I guess that's a me question, Judith, and thank you. Unfortunately, the answer to that is currently no, unless they happen to be a nurse practitioner. The Canberra Script, well, the real-time prescription monitoring across the country only enables access by prescribers and pharmacists. We do have some current access authorities to the original DAPA system, but we've turned that off now. If you have any concerns about this on an ongoing basis, please do get in touch with me. I'm happy to discuss that with you further, but it is something that currently the other states and territories are not wanting to give access to non-prescribers and non-pharmacists in the system. So that's the legislation at the moment.
Thanks, Amanda. And you've posed a question. What about for a patient that visits whichever pharmacy they're near? Is it difficult to change pharmacy regularly? I think this is
relates to the previous question about being able to have, you can have an active script and multiple pharmacies can access it. It just is that registration process that Regina showed the demo of. So they just need to click that button to register the patient at their pharmacy, then they can use it at whichever pharmacies they go to.
I guess it comes down to patient choice. They're free to go wherever they wish. So yeah, it's up to the pharmacy whether they sign them up or not, which I hope they will.
Yes, that's what we want. All right, I think I've got one last question here from Peter. Can a teenager cancel their parents' access to their MySL?
Do you want me to have a go at that?
Yes.
It really depends on, I do have to look it up, the ACT legislation on when that actually can happen. So in other states, it's 18, in some states it's 16. So just double check your jurisdiction when you become a legal adult, which then will allow them to cease anyone accessing their MySL. So yeah, I don't actually know off the top of my head what it is for the ACT. Sorry, I'm based in Victoria, but I can look it up and send it over us, unless someone else on this call knows what the legal age is. No, I'll look it up and I'll send it over.
Thanks. Thank you, Reg. All right, I think Peter, Amanda's asking if you know the answer. All right, so Reg, I think Reg will search for it and send us. We are gonna send a post-event email once the recording of this event is already in our YouTube channel. So we'll send an email with all the presentation slides, with all the links to resources and contact details as well. I guess I don't have any more questions, but before we go, again,
Russ, I just noticed that Peter's actually asked me about that question, so I was trying to type an answer, but I think that I'm interested in the variation between the regulatory aspects of the system, which maybe Reg might be able to find for us, versus a teenager or youth right to their own healthcare. So I think they're two separate questions, but I'm looking forward myself to getting Reg's answer to the more broad answer around if there's an absolute age or if it's just at the guidance of a consumer who wants to have access to their own healthcare. We all know that some of those are 13 and totally on top of everything, and others are 19 and still want mum and dad to help. So I don't know that there's a particular age.
Thanks for the clarification. Yeah, so before we go, just a quick reminder again for our participants to please answer the post-evaluation survey, because that's going to help us really in improving our events. I would like to thank all our speakers tonight and all those who stayed with us and attended this event. We'd like to plug a little bit. So the digital health team in CHN has created a HSI toolkit for practice accreditation. It's a resource for general practices regarding practice accreditation that you can find in our CHN website under the Quick Library tab. So it's a hard work from all the teams here in CHN, composing of health pathways, digital health, aged care, and indigenous health, mental health, and palliative care teams. So please check that out. And again, yep, no more questions. Thanks everyone for this lovely webinar, lovely night. I wish you all the best. Thank you. See ya.
Thanks, Russ. Bye,
Thanks,
everyone.
Kathy. Thanks, everyone.
Thank you.
Bye.